What if the world's most debated health agency can't actually tell countries what to do? Today we're unpacking the World Health Organization, what it really does, where it's fallen short, and whether do we still need it. Welcome to Inside Global Institutions, where we take a clear, balanced look at how the world's international organizations actually work. Today we'll cover what the WHO is and isn't, why the world created it, what it has done well, where it struggled, and what practical reforms are on the table. The WHO was founded in 1948 as the United Nations Specialized Health Agency to help all peoples achieve the highest attainable standard of health. Here's the key point. The WHO is designed to be a coordinator, reference, and standard setter, not a global health police force or the world's doctor. It advises, issues guidance, and can declare an international alert such as a public health emergency of international concern. But it cannot override national laws or force a country to adopt specific policies. Member states retain sovereignty. This means if the country does not wish to follow its guidance, it can simply ignore it. When you hear that the WHO mandated something or took away sovereignty, that's a misconception. The organization's strength is convening and turning science into shared norms, not coercion. But then, why have an organization like this at all? Well, because disease doesn't stop at national borders. Pandemics, antimicrobial resistance, and tobacco marketing are collective action problems. Without a trusted convener to share data, set standards, and nudge cooperation, every country would pay more and get less. That's the function the WHO performs. The WHO led the global eradication of smallpox, one of humanity's great public health victories. Through the Global Polio Eradication Initiative, wild poliovirus cases have dropped by more than 99%. Only a couple of countries remain endemic, and even with setbacks, progress continues. Another success of the organization is the Framework Convention on Tobacco Control. The first global health treaty shows the WHO's unique ability to negotiate norms with real-world impact, from smoke-free policies to advertising restrictions. During COVID-19, the WHO co-led COVAX, coordinating nearly 2 billion vaccine doses to 146 economies. It wasn't perfect, but it softened the worst inequities when markets were broken and supply was scarce. After Ebola, the WHO enhanced the Health Emergencies Program to improve incident management and field response. Reforms have come in waves. Each crisis exposes gaps, then triggers changes. Across different emergencies, the big criticisms repeat. Delays in sounding the alarm, shifting guidance, inconsistent early messaging during outbreaks, inequity in access to countermeasures, and limited power for enforcement. The problem is WHO can recommend, but it cannot compel. A recent scoping review of COVID-19 criticisms found these themes across many stakeholders, echoing earlier H1N1 and Ebola debates. Some of this is on the WHO due to communication missteps, internal coordination challenges, and tension between headquarters and regional offices. But much of it is structural. The WHO's powers are deliberately limited, and it relies on what countries share when they share it. And if a country does not wish to share the information, there is little the WHO can do, which furthers the communication challenges for the organization. Then there's money. Historically, under 1/5 of the budget has come from mandatory dues. Most funding is voluntary and earmarked, which can skew priorities and limit flexibility in crises. When major donors shift positions, programs feel it, like with the recent case of the United States withdrawing and stopping all donations to the organization, which have had a deep impact in the organization's scope and ability to respond to certain global health challenges. And then we have the sovereignty reality. The WHO's leverage is largely reputational and normative. It cannot force data disclosure or policy changes. Cooperation depends on countries' political will. That's frustrating in a pandemic, but it's how member states designed the system. There are several myths surrounding the organization. Let's discuss some of them. First myth, the WHO can dictate national policies, lockdowns, or vaccine mandates. Reality, it really cannot. The WHO issues guidance and recommendations. Countries decide what to adopt. Second myth, the WHO is captured by a single government or by industry. Reality, earmarked funding does influence flexibility and agendas, but broad oversight and multiple donors complicate simple capture narratives. The deeper problem is the financing model, not a secret hand. This is also changing as WHO is requesting donors to not earmark the donations so the organization can distribute it on a priorities and needs basis. Third myth, the WHO failed at COVID-19, so we should replace it. Reality. Although there were some missteps and learnings from the COVID-19 response, the organization has made big strides to address these, and on the other hand, building a new body wouldn't fix sovereignty and financing constraints. Most experts argue for focused reform of the WHO, not wholesale replacement. This is something the WHO is actively doing in the restructure of the organization. So what is next? Some of the practical reforms the organization is actively doing or aiming towards are 1. Update the rulebook. Modernize the international health regulations and negotiate a pandemic accord that clarifies expectations, data sharing, early warning, and benefit sharing without undermining sovereignty. 2. Fix the money. Increase assessed contributions and reduce earmarking so the WHO can invest in core readiness and respond faster. 3. Communicate better. Build faster science to guidance pipelines, pre-approved message maps, and multilingual assets to avoid early mixed messages. 4. Align operations. Tighten the seams between headquarters and regional offices, clear incident command, surge rosters, and transparent dashboards. 5. Use law and frameworks when it works. The FCTC shows the WHO's ability to broker impactful treaties. Similar strategies could target alcohol harms, marketing to children, or antimicrobial resistance. Of course, these are complicated by the different stakeholders looking out for their own interests, but the effort needs to continue. So do we still need the WHO? Without a doubt, yes, as a trusted convener, standard setter, and knowledge broker, not as an enforcer that it was never designed to be. If countries clarify the rules, fund the core work, and invest in clear communication, the next global health crisis can be handled much better than the last. Thank you for watching Inside Global Institutions. If you found this overview helpful, please like, subscribe, and tell me in the comments what one reform would make the WHO more effective. See you next episode.